Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 9 of the Neurology chapter. We're going to start by talking about pharmacology, beginning with glaucoma. As noted previously, the goal of glaucoma therapy is to lower intraocular pressure to prevent further damage to the optic nerve. 5 pharmacological groups can be used, and these are outlined in Table 13-10. The first is the adrenergic agents, which include bromidine and epinephrine. The mechanism of action is to decrease aqueous humor production. Side effects include stinging, mydriasis, which is contraindicated, so it's contraindicated in closed-angle glaucoma. Second group is the beta blockers, which includes timolol and betaxolol. The mechanism of action is to decrease aqueous humor production. Side effects are more systemic and include bradycardia and heart block. The third group is the carbonic anhydrase inhibitors. These include acetazolamide, dorzolamide, and brinzolamide, and these also decrease aqueous humor production. Side effects are systemic and include bitter taste, weight loss, depression, and malaise. The fourth group is the cholinomimetics. They're direct-acting ones, including pilocarpine and carbachol, and indirect, which is physostigmine. The mechanism of action is to increase trabecular outflow via ciliary muscle contraction, and side effects include cyclospasm and meiosis. Finally, the fifth group is the prostaglandin analogs. An example of this is latanoprost, which increases uveoscleral outflow. Side effects includes lengthening of the eyelashes, hyperemia, and iris browning. Now let's talk about opioids. Opioids are a large class of drugs that act as agonists by binding the opioid receptors, mu in the case of morphine, delta in enkephalin, and kappa, dynorphin, which are found in the central and peripheral nervous system in the GI tract, leading to decreased synaptic transmission of various neurotransmitters. For example, acetylcholine, serotonin, norepinephrine, glutamate, and substance P. Common opioids that you will encounter in the clinical setting include morphine, fentanyl, codeine, hydromorphone, oxycodone, dextromethorphan, methadone, and meperidine. Clinically, they're used for analgesia, but some are used for cough suppression, such as dextromethorphan, for diarrhea, including loperamide and diphenoxylate, maintenance therapy for heroin addicts, methadone, and acute pulmonary edema, morphine. As a result of frequent or excessive dosing, side effects can develop, such as meiosis, which is pinpoint pupils, constipation, respiratory depression, and CNS depression. Over time, patients can develop opioid tolerance by neuroadaptation through receptor desensitization, which leads to reduced analgesia effect. No tolerance develops to constipation and meiosis. In case of opioid overdose, an opioid receptor antagonist can be used. Naloxone is short-acting and is used intravenously. Naltrexone is longer-acting and can be used orally. And naloxone also is now available as a nasal spray. Newer opioids have been created to reduce side effects. Tramadol, a very weak opioid agonist, is commonly used for chronic pain, but is also known to decrease the seizure threshold. Butorphanol, a kappa agonist and partial mu agonist, is used for migraine headaches and labor and delivery because it causes less respiratory depression. Now let's talk about epilepsy. Anticonvulsants, also known as anti-epileptic drugs or AEDs, were created with the goal of suppressing rapidly firing neurons that start a seizure. In addition to seizures, anticonvulsants are also used as mood stabilizers to treat bipolar disorder, which is discussed more in Chapter 14. The two general mechanisms of actions of AEDs are inactivation of voltage-gated sodium channels or increased GABA signaling. Table 13 lists the common AEDs, and we're going to go through those in some detail now. So the first group are the benzodiazepines, which includes lorazepam and diazepam. General uses, it's the first line for acute seizures. Side effects include sedation and respiratory depression, and some comments are that tolerance or dependence may develop. Phenytoin and fosphenytoin are used for partial seizures and are first line for tonic-clonic seizures. Side effects include pseudolymphoma, megaloblastic anemia, gingival hyperplasia, peripheral neuropathy, hirsutism, nystagmus, and ataxia. These medications can produce lupus-like syndrome. They're teratogenic, and they're class 1B antiarrhythmics. Carbamazepine is used for partial seizures, is first line for tonic-clonic seizures, and is also used for trigeminal neuralgia. Side effects include agranulocytosis, aplastic anemia, liver toxicity, SJS, SIADH, diplopia, and ataxia. With carbamazepine, you need to check the CBC and liver function tests to make sure that side effects are not developing. This medication is also teratogenic. Gabapentin is used for partial and tonic-clonic seizures. Side effects include sedation, ataxia, and tremor. This medication is also used in peripheral neuropathy and for bipolar disorder, as well as for anxiety disorders. Topiramate is used for partial and tonic-clonic seizures. Side effects include mental dulling, sedation, kidney stones, and weight loss. This medication is also used in migraine headache prophylaxis. Lamotrigine is used for partial and tonic-clonic seizures. Side effects include dizziness, ataxia, sleepiness, nystagmus, headache, and SJS, which I didn't mention previously, but is Stevens-Johnson syndrome. Lamotrigine is contraindicated in myoclonus. Phenobarbital is used for partial and tonic-clonic seizures. Side effects include respiratory, cardiovascular, and CNS depression in overdose, and can also result in dependence. Phenobarbital exacerbates porphyria, thus it is contraindicated in those cases. It's first line in the treatment of seizures in neonates. Valproic acid is used for partial absence seizures. It is also first line for tonic-clonic seizures. Side effects include fatal hepatotoxicity, neural tube defects, tremor, weight gain, and agranulocytosis. You need to check CBC and LFTs with valproic acid. Ethosuximide is first-line treatment for absence seizures. Side effects include fatigue, GI symptoms, headache, rash, and Stevens-Johnson syndrome. Vigabatrin is used for infantile spasms, complex partial seizures, and secondary generalized seizures. Side effects, it's a teratogen. It can result in retinal toxicity and can cause CNS and GI symptoms. This medication is a structural GABA analog acting as a suicide GABA transaminase inhibitor. Levetiracetam is used for partial onset, myoclonic, or tonic-clonic seizures. Side effects include CNS side effects such as somnolence and headache. Can also cause neuropsychiatric side effects, as well as Stevens-Johnson syndrome and toxic epidermal necrolysis. This medication modulates GABA and glutamate release. Lacosamide is used for partial onset seizures and diabetic neuropathic pain. Side effects include it being a teratogen. It causes neuropsychiatric side effects as well as CNS and GI side effects. This medication is a functionalized amino acid acting on voltage-gated sodium channels. Tiagabine. This medication is used for epilepsy, anxiety disorder, and panic disorder. Side effects include dizziness and changes in color perception. This medication increases GABA levels by blocking GABA reuptake. Now let's talk about anesthetics. Anesthetics provide a reversible loss of sensation. They can be classified as local or general. local or injected into a wound, and general include inhaled anesthetics that cause whole body anesthesia. General anesthetics are used to cause a reversible loss of consciousness through the inhalation or intravenous administration of the anesthetic to induce and maintain a state of unconsciousness. Inhaled anesthetics, in order from highest to lowest potency, include methoxyflurane, halothane, enflurane, isoflurane, and nitrous oxide. Intravenous anesthetics include barbiturates, benzodiazepines, ketamine, etomidate, and propofol. The more lipid-soluble the drug, the more potent it is, and the faster the induction and recovery time. This is inversely related to the MAC, the minimal alveolar concentration, which is used as a marker to compare various anesthetics. Thus, the more lipid-soluble and potent anesthetics have a low MAC. Anesthesiologists use the MAC of an anesthetic along with other variables such as ventilation rate, tidal volume, atrioventricular concentration gradient, and blood solubility to control general anesthesia during surgeries. Local anesthetics act at a distinct site to prevent transmission of nerve impulses by binding to fast-acting sodium channels. The two general classes are esters, which include procaine, cocaine, and tetracaine, and amides. All of these have two I's in the name and include lidocaine, bupivacaine, and mepivacaine. General side effects include cardiovascular toxicity, such as arrhythmia seen with cocaine or bupivacaine, methemoglobinemia, which is seen with benzocaine, seizures, and hypotension or hypertension. It is important to note that if a patient has an allergic reaction to an ester anesthetic, an amide anesthetic should be administered instead. Malignant hyperthermia, or MH, is a rare, life-threatening condition that results from inhaled anesthetics and succinylcholine. It is caused by an autosomal dominant inherited mutation in the ryanodine receptor gene, which results in uncontrolled increased skeletal muscle metabolism. When malignant hyperthermia presents, patients are in a hypercatabolic state, resulting in a high body temperature, tachycardia, tachypnea, rigid muscles, rhabdomyolysis, and increased oxygen consumption and carbon dioxide production. Treatment consists of stopping the triggering agent, administering dantrolene, and providing supportive therapy aimed at correcting the hyperthermia, acidosis, and organ dysfunction. This is the end of this section. In the next, we're going to pick up with neuromuscular blockade.